We looked at CDC recommendation for HIV pre-exposure prophylaxis and post-exposure prophylaxis. We evaluated and managed common drug-drug interactions, and we looked at patients who experienced intolerable adverse effects and how to manage them. Now, let's educate an HIV patient on important lifestyle modifications.
So now that we have really good potent HIV regimens, our HIV patients are actually living longer. So now we have been able to actually study and see, how does aging affect HIV patients? Because before, patients would die within 10 years of having HIV. So we couldn't do these studies before. In fact, you can see that in the 1990s, a lot of patients would die as they age, like very quickly. And then, throughout 2000s, as we improve treatment, more and more patients are actually living longer compared to the non-HIV infected patients. And this was a study from Denmark. These comorbidities include hypertension, which is the most common one, but also you can see HIV patients are more likely to have MI. So when you compare, so orange is HIV infected, blue is HIV uninfected. You can see significant difference in MI, but also peripheral arterial disease, when you also CKD. So factors related to non-AIDS comorbidities, obviously aging is a huge part of it, but unfortunately we cannot do anything about aging.
And then the other thing is that chronic HIV infection will lead to chronic inflammation. So even in patients who have undetected viral load, there will be chronic inflammation. And as we know, inflammation can lead to fibrosis and multi-organ damage over many years.
There's ART toxicity, so whether it's TDF causing bone toxicity or nephrotoxicity, that's something important for the pharmacist to monitor. So if someone is losing bone density, you may want to intervene and switch them from TDF to TAF or other regimens that are not as toxic.
Another thing is that these patients, based on their risk factors, they could also be co-infected with other viruses such as hepatitis C.
Of course, obesity, exercise, and diet and smoking are the most important lifestyle modifications. And the reason is HIV patients are at high risk of having cardiovascular disease, and because of that, these are things that are associated with cardiovascular disease. So it is extremely important to provide education to HIV patients who would benefit from weight loss. It's important for them to exercise, and it's important to also give them education about diet. In fact, most HIV clinics actually have a dietitian as part of the team, so that they actually get a comprehensive education about diet. So dietitians have an important role in the care of the HIV patient. Now, when it comes to so you can provide education for weight loss, exercise, diet, and smoking. The most important out of all of this is smoking.
So these things can lead to inflammation, dyslipidemia, insulin resistance, and decreased physical functioning, which over time can lead to end organ disease such as cardiovascular disease, CKD, metabolic syndrome, and neuropsychiatric dysfunction. Again, most ART agents are generally well tolerated. When it comes to NRTIs or NUCs, older NRTIs are more likely to cause dyslipidemia. Newer NRTIs are less likely to cause dyslipidemia. TAF in particular can increase triglyceride, LDL, and HDL. But overall, the ratio of total cholesterol to HDL is not changed. Newer NRTIs are unlikely to cause insulin resistance. Of course, we have discussed that TDF can, reduce bone mineral density, and TAF significantly less likely to do this. And when it comes to bone marrow suppression, this specifically happens with older NRTIs. So zidovudine is one of the older NRTIs that we still have on the market. And then with cardiovascular disease, abacavir is associated with MI, which is kind of controversial because FDA has not found a correlation between abacavir and MI, whereas some observational studies have. When it comes to integrase inhibitors, the boosted elvitegravir is also likely to increase triglyceride, LDL, and HDL, but it doesn't really cause anything else. Protease inhibitors, especially the older ones, were associated with dyslipidemia. Darunavir and atazanavir are, they can still increase triglyceride, LDL, and HDL, but not as much as some of the older protease inhibitors. And then with NNRTIs or non-NUCs, efavirenz in particular can slightly increase triglyceride, LDL, and HDL. So in the 2018 American Heart Association guidelines for cholesterol management, they actually added HIV patients as one of the risk factors for having atherosclerotic cardiovascular disease. So they did say that for patients who are 40 to 75 years of age with LDL 70 to 189, and this is in the absence of clinical atherosclerotic cardiovascular disease, in the absence of diabetes. So if someone doesn't have those things and LDL is 70 to 189, if you calculate the 10-year risk score and it's 7.5 or higher, then someone who is also infected with HIV, they can benefit from statins more. So if you had a patient who you weren't sure if you should start a statin, but they had HIV, so that can push you toward actually prescribing a statin because they're more likely to benefit from it. And of course, these are the statins that are recommended, which I'll explain in a minute. So the following year, in 2019, the American Heart Association actually released guidelines for cardiovascular disease in people living with HIV. So this is HIV specifically, and they had two types of recommendation. One was lifestyle optimization, and one was pharmacoprevention of cardiovascular disease in HIV. So at the top of the lifestyle optimization is smoking cessation, followed by limiting alcohol consumption, increasing physical activity on a regular basis, and of course they refer to the 2018 guideline for dietary guidelines, which emphasize vegetable, fruits, legume, healthy protein sources, whole grains, and non-tropical vegetable oils. And they wanted patients to limit intake of sweets, sugar sweetened and artificially sweetened beverages, as well as red meats. When it comes to pharmacoprevention, in general, there are 4 groups of patients who benefit from statin therapy. And this is similar to non-HIV infected patients, but this guideline, this algorithm is specific for HIV patients. So for secondary prevention, is basically someone who already had an MI, stroke, or peripheral arterial disease. So someone who already had an event, you want to prevent another event. So that would be secondary prevention. And these are patients aged 21 or older with clinical atherosclerotic cardiovascular disease, and they will be considered high risk. So they need high risk approach. The rest of the groups who need a statin would be primary prevention. So these are people who have not had an event yet, but we want to prevent them from having an event for the first time. So it would be, so the second group would be patients with a very high LDL, so LDL 190 or higher. That would be high risk. The third group would be diabetic patients aged 40 to 75. And then the last group would be people without diabetes, without high LDL, and without clinical atherosclerotic cardiovascular disease. And in these patients, we calculate atherosclerotic cardiovascular disease. And they did have 3 different calculators that you can use. So the most famous one that's commonly used nowadays is the 10-year atherosclerotic cardiovascular disease risk score. And they did say that you can, if it's 7.5% risk or higher, there will be high risk. If it's less, it will be low risk. Now, they do say that these calculators did not have HIV patients in them. And in general, HIV patients are 1.5 to 2-fold they have 1.5 to 2-fold greater risk of having cardiovascular disease. So whatever you calculate, it's more likely higher in people living with HIV. So for example, if you calculate it to be 6.5, in a HIV patient, it will likely be more than 7.5, so you can consider them high risk. And in high risk patients, basically you go to this green area. Of course, you start with lifestyle modification, so such as smoking cessation, and then you want to use a lipid lowering drug therapy, statins primarily. Whereas for patients who have low risk, statin therapy may not be indicated. And then when it comes to smoking, they looked at smoking cessation in people who are infected with HIV and compared that to people who had smoking cessation but they did not have HIV. So here on the y-axis, we're looking at the incidence of myocardial infarction, and on the x-axis, we're looking at the time in years. So you can see that the lowest risk of MI is in patients who do not have HIV and who never smoked. And when you compare that to HIV positive patients who never smoked, you can see this is pretty similar. So this slightly higher in HIV patients who never smoked, but still higher in HIV positive patients. Now when you compare to people who were previously smokers and did not have HIV, so that's even a history of smoking increased the risk of MI more than HIV did. But when you compare former smokers who actually have HIV positive, you can see this is significantly higher. So a combination of HIV and smoking is very detrimental as far as incidence of MI. And you can see the maximum risk of MI is in patients who are HIV positive, who are current smokers. So, smoking cessation, you can see that it will reduce the rate of MI significantly. To make things worse, about half of people living with HIV in the US are current cigarette smokers. And cigarette smoking is not only a risk factor for MI, but also a risk factor for stroke, for lung disease such as lung cancer, emphysema, and infections such as bacterial pneumonia, tuberculosis, and pneumocystis jirovecii pneumonia. Now, one of the problems with smoking cessation is that for majority of patients, it's difficult to achieve smoking cessation. In fact, the rate happens to be in the long term about 12 to 15%, at least in the studies. So if you encounter patients who are unable to quit despite intensive intervention, including pharmacological intervention, an alternative goal for smokers who cannot quit is cutting down. And basically what that means is that reducing the number of cigarettes per day is actually has been shown to have survival advantage compared to heavier smoking. And studies have shown that most smokers living with HIV can successfully cut down their tobacco use within 24 weeks. So, when you provide education to patients, you can talk about weight loss, you can talk about statin therapy, you can talk about diet and exercise, but the number one recommendation to discuss with patients should be smoking cessation, or at least cutting down on cigarettes per day.